Go to another very common condition that we see in our clinic. CRVO in the young, can we help them? By Dr. Parvathy R.
Good afternoon all. Today I'll be presenting a case of a 37-year-old lady who is a teacher, presented on 22nd of October with sudden onset of defective vision in the right eye, 2 days duration. It was painless progressive. There was no previous medical or ocular history. She had history of anemia 8 years back during her postpartum period and it was treated. And on examination, the affected eye best corrected visual acuity was 6.9 in 8 and left eye it was 6.6 in 6. Anterior segment examination and intraocular pressure were normal in both eyes, and fundus examination of left eye was within normal limit, and right eye showed a mild disc hyperemia with dilated tortuous retinal veins with peripapillary flame-shaped hemorrhages and multiple blot and dot hemorrhages seen in the retina. In all the quadrants it was seen, and OCT showed mild hyperreflectivity in the inner retinal layers, and there was no macular edema. And on systemic examination, her blood pressure and other system examination were within normal limits. She had pallor. We have sought physician and cardiology consultation. And on arrival of the blood report, she was found to have anemia with low HB of 8.2, reduced PCV, MCV, MCH and MCHC. And her total count was normal, ESR was elevated and platelet count was 3.1 lakh. And since peripheral smear also showed microcytic hypochromic anemia, her cardiology evaluation and carotid Doppler were normal. Her fasting sugars, fasting lipid profile, renal function, coagulation profile were normal. And since she was a young patient, we did the panel for young occlusion, and all of this hypercoagulable state profile came to be normal. So we made a provisional diagnosis of impending CRVO, most probably secondary to anemia. And she was started on Nepafenac eye drops, and anemia correction was started with parenteral iodine sucrose 100 mg. IV infusion was given once in 2 weeks, and tab equaspirin was started as advised by the cardiologist. And she was reassessed after 10 days. The fundus was becoming normal. The disc hyperemia has reduced. The vessel caliber has reduced. The peripapillary hemorrhages resolved, and few blot hemorrhages were presenting. And her visual acuity also improved to 6 parts and near vision N6 parts. And she was advised to continue parenteral iron supplementation. And she was on follow-up. And this was the OCT in which the inner retinal layer edema is resolving. And then 4 weeks later, she noticed sudden drop of vision in right eye on waking up, and her best corrected visual acuity in right eye was 6.36, N36, left eye was normal. And on examination, right eye anterior segment was normal. There was no angular iris neovascularization. Intraocular pressure was 15 millimeters, left eye was normal. And fundus revealed again a hyperemic disc with multiple peripapillary hemorrhages, increased venous caliber and tortuosity. And OCT showed presence of fluid. And at this stage, she was on having parenteral iron supplementation, and her hemoglobin has improved at that stage to 9.9. And she was started on calcium dobisilate, continued iron sucrose. We advised FFA at this stage, but the patient wanted to wait. And 2 weeks later, it came as a full-blown occlusion. But at this stage, her visual acuity was improving and the patient was happy. And on OCT, the retinal fluid has reduced. And then we kept her on observation. It's going. And 8 weeks later, she reported back with a best corrected visual acuity of 6.9 parts, N12, left eye 6.6, and anterior segment was normal with no evidence of any neovascularization, and pressures were normal. And her fundus showed normal disc, and vessel caliber, venous dilatation and tortuosity has reduced. The hemorrhages has resolved. There were few X-ray near the macula, and OCT showed normal foveal contour and intact outer layers. And at this stage, her hemoglobin was 11.1 and she was on oral iron supplementation. So my question is, actually, this iron deficiency anemia can cause central retinal vein occlusion, but usually it is at a very low level of hemoglobin. This patient was having a hemoglobin of 8.2 at the first stage and then 9.9. Again, then also she developed moderate anemia. There are very few case reports of central retinal vein occlusion. So anything, am I missing anything else? And would FFA will help in the diagnosis at the time of reocclusion?
Yes, anemia causing vein occlusion is not a very common cause that we see. But if you ask why did it happen at 9.9, actually this impending CRVO is not a term that is used anymore. Now it is when you have a few hemorrhages, disc edema, and you think it with venous tortuosity, then it is a non-ischemic CRVO. You can call it an early non-ischemic CRVO, which may progress later. So it is basically a non-ischemic CRVO with vision good, not much macular edema. And the 9 point, High-Ray has showed how the thrombus can progress inside the vein and then convert we know that there is about 18% chance of conversion to ischemic CRVO. All non-ischemic CRVOs can convert to ischemic CRVOs. So some amount of thrombus progression, once it has occurred, will be there. So it is not like the patient developed a recurrent CRVO. The CRVO was there. That CRVO, the thrombus has progressed and become more severe. That is what has happened in the patient.
Yeah. In between, actually, her venous dilatation, that stagnation has reduced. And again, it developed. That was the confusion.
Okay. I would actually send her to a hematologist for a full workup, just in case we have missed anything. Cardiac, she has already
Yeah,
done.
her electrophoresis was also done. It was also normal.
Also normal.
And reticulocyte count was reduced, and there was no other blood malignancy. There was
There are
nothing.
some case reports of anemia causing CRVO, but again, it is not common. So we have to keep the patient under follow-up. But I want to highlight another thing that happened. It happened to me. So the patient came like this 36-year-old patient, very mild CRVO picture, no edema. I sent her with a usual workup. We don't do the entire full-blown hematological workup in the beginning. No protein C, protein S. I just gave her a routine workup and told her to get a physician consultation and everything, and told her to come back with the results, and just started her on an epafenac eye drops. And she came back the next day with a combined occlusion. The next day with combined occlusion of artery and vein. And then they were like very agitated because this is like many years back, 10-15 years back. They were very agitated because we came and saw you, doctor, and you did not tell us that she's going to lose vision, and you did not do anything. But again, it's not something I could have prevented. Even if I had sent some investigations, it's not something we could have prevented. But I want you to warn the patient that it can increase. So this kind of like when it comes ഇപ്പൊ ഒന്നും ചെയ്യണ്ട, കുഴപ്പമൊന്നുമില്ല, ഇങ്ങനെ കാർഡിയോളജിസ്റ്റിനെ കാണൂ, അവരെ കാണൂ, ഇവരെ കാണൂ, they think we are avoiding them. So that has to be conveyed very clearly that you have a problem. We are trying to get to the bottom of it, but it can increase, and if it increases, you will require further ocular intervention. That patient had APLA. She was APLA positive. She had a bad obstetric history. So again, young patient comes to you with CRVO, lady, ask for the obstetric history. Immediately send the APLA. APLA takes 5 days to get the result. So if you can send it on the first day itself, by the next review, you will have the result with you. Other common thing that we miss out is homocysteine. Serum homocysteine, raised homocysteine can cause CRVOs. Other workup, of course, if you don't get hypertension, is increasingly the cause for CRVO in younger people, because all 30s people have hypertension now. So that again has, and they will deny it, absolutely no BP. So you have to send to a physician. That could just be the cause. Otherwise, a full workup. The other one is a vasculitic workup. The one aspect that you have not done here, because the fundus does not look vasculitic, but that is another workup that you can do. For the you have sent the ANA, I think. ANA, PLA was also done.
And at the time of second time, we sent for the whole connective tissue panel as advised by physician. Everything was negative.
It's worth going the whole way with young CRVOs because you will be saving their lives.
Okay, so
Thank you, Dr. Parvathy.
okay. So just I want to send, there is no definitive treatment guidelines for young patient with CRVO, but it is similar, essentially similar to elderly with injection if there is any vision loss with macular edema. And condition that may predispose to younger patient to CRVO carry significant systemic mortality and morbidity and often require further investigation. So we have to do a proper systemic workup and treatment of the predisposing conditions.
Anemia may
Thank
not
you.
be the reason for CRVO here, because for the CRVO to occur, you should have two things. One, there should be alteration in the blood circulation. Other reason is blood vessel abnormalities. Anemia cannot cause both these things.
Yeah.
Yeah.
Some case reports are there. In moderate, most cases it will be in severe
Madam told we
anemia.
have to work more on vasculitis or something.
Okay, thank you, ma'am.